Imagine going to a pharmacy for a really serious chronic pain condition.
Right.
But instead of, a pharmacist in a white coat handing you a standardized plastic bottle with like exact milligrams and strict medical instruction, you walk into a room with neon lights and loud music.
Yeah, exactly.
And there's a bud tender who offers you this brightly colored bag of gummy bears.
Oh, boy.
While talking about, good vibes and head highs.
Yeah.
For patients managing really complex chronic illnesses like Hypermobile Ehlers-Danlos Syndrome or hEDS,
Right.
this culture clash it's just this incredibly confusing reality of medicinal cannabis. You have a patient who is desperate for clinical relief, and they're forced to navigate this retail environment that was built almost entirely for recreational consumers.
It's a profound medical and cultural disconnect. It really is.
Yeah.
Because the commercial cannabis space, it can feel entirely alienating for someone who just wants to manage their debilitating joint pain.
Right, yeah.
Or just get a full night of sleep. They aren't looking for a recreational experience.
Right, oh, yeah.
They're looking for a reliable, safe pharmacological tool. But the medical data they actually need is it's buried under a mountain of aggressive industry marketing.
And digging out that medical data, that is our mission today.
Yes.
We are looking at a stack of medical literature. Specifically, we're zeroing in on Chapter 20 of the medical guide Disjointed.
Excellent book.
Yeah, and this chapter is authored by Dr. Jordan Tishler. And what he does is he strips away all the neon packaging to look at the actual physiological role of cannabis in managing chronic pain and sleep for the hEDS patient population specifically.
Which is so needed.
It is.
Yeah.
If you are dealing with chronic illness, or honestly, if you just want to understand the actual science behind this massive multi-billion-dollar industry, consider this deep dive your vital shortcut to being truly well-informed.
Absolutely.
Because what we cover today might completely reframe how you view pain management. And it will absolutely change how you look at every single dispensary and CBD shop on the corner.
It really will.
Okay, let's unpack this.
Let's do it.
To understand how cannabis fundamentally works for hEDS, we first have to redefine our entire baseline concept of what pain actually is.
Right.
Both biologically and psychologically.
Yes. And to do that, we really have to look at Dr. Tishler's specific clinical background.
Okay.
Because it heavily informs his whole perspective. He spent 20 years in emergency medicine.
Wow, 20 years.
20 years. And 15 of those years were at the Veterans Administration.
Oh, wow.
Yeah. So in the ER setting, he observed this constant tragic stream of veterans coming in profoundly sick from the very things they were using to manage their pain.
Like opioids and...
Specifically alcohol and heavy pharmaceutical pills.
Oh, right.
Their organs were failing, their bodies were breaking down. But he noticed a striking anomaly.
Okay.
The veterans using cannabis, they weren't ending up in his ER with those same catastrophic systemic failures.
Oh, interesting.
Yeah, and that observation compelled him to dig deeply into the physiological data, which led him to this completely different framework for understanding how we control pain.
I imagine seeing the sheer physiological toll of traditional substances on a daily basis.
Yeah.
That would force any doctor to question the standard protocol.
It absolutely does.
Shifts the focus from just numbing a patient to asking, well, how can we manage their reality safely over decades?
Exactly. And that long-term safety profile, it hinges on how the text makes a critical distinction regarding the human nervous system. What's fascinating here is the difference between the neurologic signal of pain and the suffering of pain.
Wait. Signal versus suffering?
Yes. From a medical standpoint, they are two entirely separate biological processes.
That feels entirely counterintuitive.
I know.
When you're the one hurting, the physical ache and the misery of that ache, they feel like the exact same thing.
They feel interwoven, definitely. But physiologically, they occur in different stages. The neurologic signal is purely objective. Okay. It is binary. It's the nerve ending in, say, a dislocated hEDS shoulder, sending an electrical impulse up the spinal cord to the brain, saying, tissue damage has occurred.
Right. Just a data point.
Exactly. But the suffering is the brain's subsequent emotional and psychological response to that signal.
Ah, I see.
It's the anxiety about whether it will get worse, the sheer exhaustion of dealing with it. It's the degree to which that electrical signal is actually bothersome to your conscious existence.
Oh, okay. So it's essentially like a car alarm.
A car alarm.
Yeah, like the neurologic signal of pain is the alarm system itself being triggered.
Right.
The hazard lights are flashing, the siren is going off,
Mm.
and normally that sound is blaring right inside your head and driving your nervous system absolutely crazy. That blaring noise is the suffering.
Exactly.
But cannabis, it acts like rolling up a thick soundproof window. The alarm is technically still flashing on the dashboard.
Right, the signal is still there.
Right, the physical source of the joint pain hasn't magically vanished, but the blaring noise just doesn't penetrate your awareness anymore.
Yes.
You've successfully separated the physical alert from the emotional panic.
That is a phenomenal way to visualize the mechanism of action, because cannabis modulates the emotional processing centers in the brain, essentially divorcing the suffering from the physical pain signal.
Wow.
Your shoulder might still technically register as painful, but you simply don't care that it's hurting.
It just stops dominating your consciousness.
Exactly. And the clinical data backs up just how effective this cognitive separation is. For mild to moderate chronic pain, Dr. Tishler notes that cannabis is roughly equivalent to opioids in terms of overall effectiveness.
Wait. Equivalent to opioids?
Yes.
To pause on that, because that is a staggering medical claim given the current opioid crisis.
It is a massive statement, but the key distinction lies in the safety profile. The risk profile of opioids is linear. The longer you take them, and the higher the dose, the exponentially higher your risk for tolerance, addiction, and respiratory depression.
Which is why they're so dangerous long term.
Precisely. But because cannabis operates through a completely different receptor system, the endocannabinoid system, it doesn't depress the respiratory drive.
Okay.
In fact, for chronic patients who are already dependent on opioids, incorporating cannabis into their regimen can actually decrease their required daily opioid dose by 40 to 80%.
A 40 to 80% reduction. I mean, that could genuinely save a patient's life.
Easily.
Or at the very least, save their gastrointestinal and liver function over a lifetime of chronic illness.
Absolutely.
But so this brings up a logistical hurdle,
Good.
right? Because hEDS pain is notoriously chaotic.
Oh, very.
It isn't just one type of pain. A patient could wake up with a sudden blinding neurological migraine, and at the same time, they're dealing with a constant dull, deep ache in their hips that literally never stops.
Right.
So if cannabis changes how we experience the car alarm, how does a patient physically apply this medicine to treat two completely different timelines of pain?
Right. So the tactical application relies entirely on the delivery method, because the delivery method dictates the pharmacokinetics.
Okay, the pharmacokinetics.
Right. How fast the medicine hits the bloodstream and how long it stays there. The text establishes two distinct medical protocols, one for episodic pain and one for constant pain.
Okay, so I'm assuming that for an acute episodic flare-up, like a sudden subluxation or a migraine,
Yeah.
you need something that bypasses the digestive system entirely so it hits the bloodstream immediately.
Precisely. For episodic pain, the required protocol is inhalation. When you inhale, the active compounds cross the lung tissue directly into the bloodstream, which results in incredibly fast onset, usually within 10 to 15 minutes.
Wow, that is fast.
It is. However, Dr. Tishler is adamant about one specific rule here.
Okay.
You must vaporize whole flower, never smoke it.
Oh, well, I can deduce why smoking is off the table.
Yeah.
A complex connective tissue disorder like hEDS is often accompanied by massive systemic inflammation.
Yes, exactly.
So combusting plant material with a lighter, you're introducing carbon monoxide, tar, a whole host of toxic inflammatory byproducts right into the lungs.
You hit the nail on the head. Smoking combusts the material. Vaporizing, on the other hand, utilizes a device that heats the raw flower just to the boiling point of the active medicine.
Okay, so no smoke.
Right. It releases it as a clean vapor without the plant matter ever catching fire, so it delivers rapid relief safely. But there is a biological trade-off.
Which is...
Because it enters the system so quickly, it also metabolizes quickly. The relief from vaporizing only lasts about 3 to 4 hours.
Ah, which makes perfect sense for a migraine that might pass.
Right.
But if a patient has constant chronic joint pain, relying on a vaporizer means they would be tied to that device all day.
Yep.
They'd medicate, feel better for 3 hours, crash back into pain, and have to medicate again. That yo-yo effect sounds exhausting.
It is exhausting, and it's terrible for regulating the nervous system. So for chronic, round-the-clock pain, patients need a slow, steady, sustained release.
Okay.
That requires utilizing the digestive tract through edibles, capsules, or tinctures. You don't take these in response to a flare-up. You take them by the clock on a strict daily schedule.
Just like regular medication.
Exactly.
Right.
Because the medicine has to be processed by the liver before entering the central bloodstream, the onset is much slower. It takes an hour or more.
Okay.
But that same liver processing extends the duration of relief to a massive 8 to 12 hours.
Wow.
Yeah. And a crucial clinical data point from the text is that edibles are actually twice as effective in terms of absorption as capsules or tinctures.
Okay, wait. As someone who advocates for chronic illness management,
Yeah.
I have to push back hard on that recommendation.
Okay, why is that?
Managing hEDS often means managing a very strict anti-inflammatory diet. Gut motility issues are rampant in this population. The idea of prescribing a patient a sugary, fat-laden, highly processed dispensary brownie every single day,
Right.
that seems wildly counterproductive to their baseline health.
And Dr. Tishler anticipates that exact resistance, and it really highlights another clash between medical needs and recreational retail.
Okay.
When the text advocates for edibles, it is absolutely not recommending recreational baked goods. Eating a massive sugar-heavy brownie is not an appropriate daily medical treatment.
Right. Okay.
In a clinical context, a medical edible can simply be a tiny 15 to 20 calorie gummy.
Oh, I see.
Yeah, the gummy is just the vehicle to deliver a highly precise dose to the digestive tract.
So we aren't talking about the food itself. We are
Yeah.
talking about utilizing the liver's metabolic pathway to stretch the pain relief over a 12-hour window.
Yes, and the necessary medical dose to achieve that is shockingly low. The text recommends a starting target of just 5 to 15 milligrams of THC.
5 to 15.
That is a fraction of what a recreational user might consume. The medical goal is consistent low-level dosing. Pushing past that 15 milligram threshold, it doesn't incrementally decrease your pain. It just drastically increases the unwanted cognitive side effects and builds up your bodily tolerance.
5 to 15 milligrams is a great tangible benchmark. Now, thinking about that timeline, if a low-dose edible provides 8 to 12 hours of relief, that perfectly mirrors the human sleep cycle.
It does indeed.
And we know that constant unmanaged pain inevitably destroys a patient's sleep architecture. So how does this specific pharmacokinetics play into the severe insomnia that hEDS patients deal with?
It plays a transformative role. The text highlights that insomnia is actually the symptom cannabis treats best,
Really?
even outperforming its efficacy for pain.
Wow.
And crucially, it achieves this without the debilitating morning hangover, grogginess, or memory issues that plague patients taking traditional prescription sleep aids like, Ambien or heavy sedatives.
That is a massive relief for patients terrified of pharmaceutical hangover.
Oh, absolutely.
But treating sleep isn't one size fits all, right? Like some hEDS patients lie awake for 4 hours just trying to turn their brains off, while others crash immediately, but they jolt awake in agony at 3 a.m.
Right, which is why you apply the different delivery tactics to the specific sleep dysfunction.
Okay.
If your nervous system is wired and you cannot initiate sleep, you employ the episodic strategy. You vaporize flour right before you get under the covers.
So it hits fast.
Exactly. It crosses the blood-brain barrier in 15 minutes, dampens the neurologic alarm, and gets you over that initial hurdle of falling asleep.
Got it.
However, if your dysfunction is sleep maintenance, waking up at 3 a.m.,
Yeah.
vaporizing at 9 p.m. won't help you because the medicine metabolizes and leaves your system after 4 hours.
So that's where the 8 to 12-hour edible becomes the primary tool.
Yes, if you take the oral gummy an hour before bed, the liver processes it slowly, providing a prolonged, steady blanket of coverage all the way through the night.
Wow, okay. You just have to reverse engineer the math to ensure you are dedicating a full 8 to 10 hours to being in bed so you don't wake up at 6 a.m. still feeling the medication.
Yeah, exactly.
Here's where it gets really interesting.
Okay.
Because I was looking at the broader physiological data in the text, and there's a very well-documented scientific paradox here. Cannabis is known to suppress REM sleep.
Yes.
And REM is our dream state. It's the phase of sleep that is deeply neurologically restorative.
So if we know as a biological fact that cannabis suppresses REM sleep, how can patients consistently report to their doctors that they are finally getting restorative rest?
If we connect this to the bigger picture, we have to critically examine how modern sleep studies are conducted.
Okay.
You are entirely correct that short-term clinical studies clearly demonstrate REM suppression. But those studies are almost universally designed to measure acute use.
Like just one night.
Exactly. They monitor a subject for a single night, maybe two. They are capturing a tiny snapshot of a much longer process. So they are essentially studying the shock to the system, not the adaptation.
Precisely. Dr. Tishler points out that in long-term clinical practice, the reality looks vastly different. Despite that initial REM suppression, his patients report deeply restorative sleep over the long haul.
That's fascinating.
His clinical assessment is that over the course of weeks and months of consistent, low-dose medical use, the nervous system adapts. Instead of an absent REM cycle, the medicine likely facilitates a more regulated, better balanced overall sleep architecture. The initial acute suppression gives way to chronic stability, which is why patients finally wake up feeling like human beings again.
Okay, so what does this all mean for the patient listening right now? They understand the biology, they want the regulated sleep architecture, and they want the 40 to 80% reduction in pain suffering.
Right.
But to get it, they still have to walk into that retail dispensary we talked about earlier.
Yeah, that's the tricky part.
They are staring at a menu screen listing 7,000 different plant strains with these ridiculous cartoonish names, and they have employees pushing shelves full of CBD products at them.
Yeah.
How are they supposed to make a clinical decision in that environment?
They make a clinical decision by ruthlessly ignoring the marketing.
Just ignore it all.
The commercial cannabis market is a minefield of pseudoscientific traps. The text dismantles the biggest one right away.
Which is?
The absolute myth of indica versus sativa.
Oh, the classic dispensary lore.
Yeah.
Anyone who has ever been near cannabis has heard this.
Yep.
Indica puts you into couch, meaning it's a heavy sedative for nighttime use, and sativa is an uplifting, energetic strain for the daytime.
It is a complete biological fabrication.
Wait, really?
The text is definitive on this point. The botanical terms indica and sativa relate exclusively to the physical shape of the agricultural bush.
The shape of the bush.
Yes, whether it grows tall and skinny or short and bushy, and its historical geography of origin. The terminology has absolutely zero correlation to the chemical effects on the human nervous system.
No way.
When analyzed in a lab, the chemical profiles of these strains overlap entirely.
Wow. If the daytime and nighttime divide is a complete fiction, then millions of consumers are experiencing a massive placebo effect driven entirely by packaging and the power of suggestion.
It is placebo and marketing. Dr. Tishler uses a highly relatable analogy. Debating indica versus sativa is like agonizing over whether to order a pepperoni pizza or a mushroom pizza.
Okay.
You might have a psychological preference based on the box it comes in, but physiologically, the mechanism is identical. Both are just going to make you full.
Okay, so if the strain names and the indica sativa labels are totally useless, what chemical markers should a medical patient actually be looking for on the product label?
They need to look for a modest, balanced THC percentage, around 15 to 20%.
15 to 20.
But more importantly, that THC must be supported by the plant's natural helper chemicals. The text clarifies these. These are the terpenes and minor cannabinoids.
Okay.
They are organic compounds that naturally modulate and smooth out the effects of THC.
Like the soundproof window we talked about.
Exactly. The problem with the recreational market is that growers have artificially crossbred plants to produce astronomical 30+% THC levels to chase a recreational high.
I see.
When you force a plant to overproduce THC, the percentage of those vital helper chemicals drops to almost zero. You lose the medical benefit and increase the anxiety side effects.
That makes perfect sense. You want the whole plant profile, not just an isolated chemical spike.
Right.
Now, speaking of isolated chemicals, we have to talk about the juggernaut that has taken over the entire wellness industry.
I know where this is going.
CBD.
Yes.
It is inescapable. It's in expensive boutique lotions. It's in gummy bears at the gas station. It's even in dog treats.
It's everywhere.
What does the actual medical text say about this CBD craze?
The expert consensus in the text is a blunt, uncompromising dismissal of the commercial CBD market.
Really? What dismissal?
Yes. When the 2018 hemp bill removed CBD from the controlled substance list, it transformed it into an unregulated FDA supplement. The text isn't saying that the CBD molecule itself is bad. The issue is that the dosing available in commercial products is wildly, almost comically inadequate for human biology.
Oh, wow. Walk me through the math. How inadequate is a standard over-the-counter CBD product?
Okay. To achieve a medically effective anti-inflammatory or pain-relieving response, clinical data shows that a human being requires a dose of 10 to 20 milligrams of CBD per kilogram of body weight.
Per kilogram. Okay, so if we take an average adult weighing 70 kilograms or about 154 pounds,
Right.
that translates to a required daily dose of 700 to 1,400 milligrams of CBD.
Exactly.
1,400 milligrams a day.
Yep.
That is staggering.
Yeah.
Most of those expensive little tincture bottles at the grocery store brag about having maybe 300 milligrams in the entire bottle, meant to last a month.
You've hit the core issue. Taking 1,400 milligrams a day would require drinking multiple entire bottles of commercial tincture every single day.
And that's
It is completely unaffordable, costing hundreds of dollars a week and functionally unavailable to the average consumer. Therefore, when someone buys a $40 tincture at the local store and places 3 drops under their tongue, any relief they feel is entirely a placebo effect. At those microdoses, it is medically useless.
Man, that is going to infuriate a lot of listeners who have spent a small fortune on these wellness products.
I know.
But it is vital information.
Yeah.
And it logically brings us to a much more serious issue. Let's say a patient with hEDS somehow does manage to access and afford a true clinical dose of 1,400 milligrams of CBD.
Okay.
How does a dose that massive interact with the heavy-duty pharmaceuticals they're likely already taking?
Yeah.
Because cannabis is safer than opioids, but it isn't completely risk-free.
We must be totally impartial here and look strictly at the physiological risks. High doses of cannabis, and specifically the CBD component, utilize the exact same liver enzymes that process many common pharmaceuticals. This can cause dangerous bottlenecks. It interacts dangerously with blood thinners like warfarin and Plavix, potentially increasing bleeding risks.
Right.
It cross-reacts with anti-epileptic medications, and it can disrupt immunosuppressants like tacrolimus or everolimus, which are critical for patients managing organ transplants or severe autoimmune issues.
That is a massive red flag for anyone managing a complex pharmacological regimen.
It is.
And beyond drug interactions, what about comorbid conditions? Specifically POTS, postural orthostatic tachycardia syndrome.
Yes.
For those unfamiliar, POTS is a form of dysautonomia, incredibly common in hEDS patients.
Yeah.
Their autonomic nervous system struggles to regulate blood vessels when they stand up, causing blood to pool in the lower body, which leads to massive blood pressure drops and wild, compensating heart rate spikes that cause fainting. How does cannabis affect that specific fragile mechanism?
It requires extreme medical caution because the physiological effects of cannabis directly overlap with the mechanics of a POTS flare. Yeah, cannabis naturally acts as a vasodilator. It relaxes blood vessels, which lowers blood pressure and subsequently increases heart rate.
Wow.
If a patient already has dysautonomia, artificially lowering their blood pressure is the exact opposite of what their nervous system needs.
Right.
Now, Dr. Tishler notes a clinical nuance. In his own practice, he hasn't actually seen his POTS patients passing out more frequently from careful cannabis use.
Okay, well, that's good.
However, the biological mechanism is undeniable, meaning it must be approached with extreme care, incredibly low doses, and strict medical supervision.
Absolutely.
The same vasodilation risk applies to patients with congestive heart failure. And we must state clearly that cannabis use is entirely contraindicated for pregnancy, breastfeeding, and driving.
Right. Let's also quickly touch on the delivery risks we skipped over. You mentioned vaporizing whole flower is safe because it avoids combustion. But every dispensary is filled with slick, convenient vape pens loaded with concentrated oils.
Yes, and the text strongly warns against vape pens and oil cartridges. The industry has not perfected that technology. The carrier oils and thinning agents used to make the cannabis liquid enough to vaporize can degrade into highly toxic chemicals when exposed to the heating element of the pen.
Oh, wow.
To protect your lungs, avoid vape pens entirely and stick exclusively to the raw, natural plant flower.
It's all about navigating the biological reality of the medicine, stripped of the marketing hype and the convenience traps.
Precisely.
So, to bring all these complex threads together, medicinal cannabis is not a magical, risk-free cure-all. And it is certainly not the cartoonish recreational drug it's historically been portrayed to be.
No, it's not.
When we cut through the societal stigma and the neon dispensary marketing, what we find is a highly specific low-dose medical tool. It relies on precise pharmacokinetics to divorce the emotional suffering from the physical pain signal, and it has a unique ability to restore long-term sleep architecture for chronic illness patients who desperately need their nervous systems to rest.
You've captured the core thesis perfectly. True health empowerment doesn't come from blindly trusting a bud tender or buying into wellness trends.
No.
It comes from understanding the actual underlying science. It comes from knowing exactly how your liver processes an edible versus how your lungs process a vapor, and refusing to fall for the placebo labels on a shiny package.
Because scientific knowledge is the absolute best defense a patient has against a multi-billion-dollar industry trying to sell them a vibe instead of a treatment.
Absolutely. And speaking of analyzing that industry, this raises an important question, one that Dr. Tishler highlights when discussing the flimsy foundations of the current CBD craze.
Oh.
We mentioned that all the hype about CBD as a miracle anti-inflammatory is technically based on published data. But here's the startling revelation from the text. 92% of medications that show success in rodent trials fail completely when tested in humans.
92% fail.
Yes.
That is a staggering failure rate.
No, it is. So if 92% of rodent success stories fail when applied to human biology, we have to critically ask ourselves, how much of our modern wellness and supplement culture, just like the massive CBD industry, is built entirely on rat data masquerading as human medicine?
Oh, wow. That is a thought that will absolutely stick with me the next time I walk down a supplement aisle looking for a quick fix.
Yeah.
It really drives home the reality that when your neurological car alarm is blaring, you don't need a placebo, you don't need a cartoon gummy, and you don't need marketing fluff. You need precision science to finally roll out the window.
Exactly.
Thank you all for joining us on this deep dive into Chapter 20 of Disjointed. Keep questioning the labels, keep digging into the actual science, and keep learning.